week to be in wound care. Bill and I are joining you tonight from Las Vegas on our Facebook Live. We've been out here teaching. Bill was teaching the WCC prep class, and I was teaching the diabetic wound cert, the DWC prep class, and we have had an amazing week, meeting a lot of students and potential wound care specialists. And I'm ready to bring Bill out. We've got a fantastic show for you tonight. So, Bill, you out there?
Here I am, surprise! Welcome to Vegas virtually, everybody. So,
Hey, what a great week! And wow, we're going to have the kickoff for WOW this week. So, if you aren't in our listening audience or not or not familiar with WOW, please check that out. It's WOW Don't Woo, and it is a fantastic conference. It is virtual this year. We're missing our friends, but man, it's a fantastic experience, and even virtually, we're getting a lot of great content this week.
and I will put a shameless plug in for my partner over there because she's doing a session tomorrow on chronic venous insufficiency and lymphedema. And if you want to learn more about what the difference is and what's going on, you got to check out what she's doing tomorrow. It's going to be amazing. Do you remember what time your program goes on there?
10:20.
10:20. So tune in, folks, for this gal's going to rock it.
Yeah, I'm excited about it. Near and dear to my heart, venous insufficiency and lymphedema. And tonight for our Facebook Live, we're going to talk about something that is near and dear to both of our hearts, right? And that is sharp debridement. So let's get rolling right into that subject. Bill, I know that I started sharp debridement way back in college, whenever I was doing my clinical rotations in a burn center. How did you get started in sharp debridement, and then how did you start teaching sharp debridement? Tell us about that.
All right, thanks. I appreciate that. Well, first of all, I want to say one of the reasons why we're doing this is because of COVID and virtual. We can't do sharp debridement at the WOW conference, so we thought we'd bring you a different flavor of sharp debridement from WOW, even though it's really not the actual hands-on training. But we'll catch you guys and talk more about that later. Basically, as a therapist, I went right into long-term care when I got out of college and was fortunately able to work under a therapist, a PT, who was my supervisor, who had been doing wound care for many years. And so I had a good mentor. And so I just started doing it. She sent me and recommended I go to a training class, which I did way, way back in the day. I can't even remember where it was. And so I started learning my wound care. But really what got me into teaching sharp debridement was when I first got my WCC, which would have been in, I believe it was November of 2003. I met Donna and Nancy, the two co-founders of WCEI then, and I was a student in the class, and we had a great week, and I was literally hanging out with those two guys after class, and chatting and just shooting the bull. And towards the end of the week, they came to me at dinner one night. We were sitting down having dinner together, and they pitched me with this idea. They're like, "Hey, Bill, would you ever consider writing a class on sharp debridement?" And I was like, it had never crossed my mind doing something like that before. And I'm like, well, yeah, sure, I could do that, And so that's where we started. I began writing the program. Again, Donna and Nancy kind of supported, they offered me any advice. They helped me develop and gave me some advice on developing the PowerPoint and the content to turn it into a good, comprehensive one-day program. And then we kind of, using the power of WCEI at that time, Donna and Nancy kind of helped market for the first couple of months to get the first few classes out there, to get the ball rolling, build up some momentum, and obviously trial the program out to make sure that it was going to be, good. And we had such great results with it that eventually I took over the program entirely and rolled it into my company, Infinitus LLC at the time, and now we're rolling it into Wound Care Gurus. But that's kind of really how I got my start. And my partner, Teresa Ferrante, who at the time also kind of helped co-author the program. And her and I went around the country teaching the program and just really enjoyed it. And the program has obviously developed over the years. And then I believe it was in 2011 when this good looking gal here kind of got brought into the fold as an adjunct professor, so to speak, because we were in a situation that neither Teresa or I were able to teach a class. And I'm like, oh my gosh, who's going to teach it? And I'd been working with Denise and her company that she was employed with at the time. This is before we were, the Mr. and Mrs. Smith of wound care and married. And so, but I'd been doing a lot of classes for her employees, so we had a good working relationship, and I knew her knowledge about wound care. And obviously, she'd seen the program, only a couple of times. And I'm like, you know what? She could probably handle it. So I reached out to Denise and said, hey, would you be willing to kind of be an adjunct professor for the team and kind of teach this class? And then after that, she taught a few more other classes on a few other locations here and there. Obviously, Teresa and I were still pretty much doing most of it full time, but she was in the background. And then obviously now that we have moved into where Denise has left the corporate world and we are just working together, rocking the wound care gurus and the sharp debridement, she's kind of more of a regular instructor for that debridement class. So that's pretty much how I got my start and how we got to where we are today.
Right. Well, thanks for the history lesson and maybe a little nostalgia there. Appreciate that. But it has been a good time. It's been a good trip. And man, I just think about all of the classes that we've had and all the clinicians, and I'm just so honored to be able to help, and being mentored by different people in the business, Donna, Nancy, even yourself, TJ. It's family. I mean, wound care can truly just be like family, and I think that's just one of the great things about this business. So, all right, enough about memory lane, because we're going to tell both of our ages here. So, what for the folks out there may not be familiar with the terms? What exactly is sharp debridement? What are we talking about? Who can perform it? So, give us a little information on that.
Sure. I also want to, before I even answer, I want to make sure to throw it out there to our watching audience. If you have any specific questions or general questions regarding sharp debridement, throw it into the comments section, because we would love, when we're done, we would love to take questions from you as well too. If there's anything that we can answer for you, specifically if you've got a situation, we're more than happy to take those. But basically, sharp debridement it's usually developed, or I should say, divided into two categories. They have surgical sharp debridement and what people call conservative sharp debridement. Surgical sharp debridement, of course, is limited to doctors and surgeons and nurse practitioners and physician's assistants. Those are the only ones that can actually technically do surgical debridement. And there is even limitations there, like our nurse practitioner colleagues and our physician's assistants, they can only do surgical debridement down to the subcutaneous level. If you need muscle or bone debridement, that has to be done by a physician or surgeon to take it to that level. Now, the other one is conservative sharp debridement. And now that can be done by almost any clinician. It varies state by state. But literally, again, doctors can do it, NPs, PAs, PTs, OTs, physical therapy assistants, occupational therapy assistants, RNs, LPNs, LVNs, and depending on the state, any one of those disciplines. But I want to clarify that it does vary from state to state. So we're not saying that all states allow all those disciplines to do it. But conservative sharp debridement is what I often, you'll hear me talk about it, I call it bedside debridement. This is where we don't have to drag the patient out to the wound clinic or the doctor's office, or worst, into the OR to do a debridement. We can do it right bedside. We could do it down in the therapy department. I've done a lot of that in my time. I'm sure Denise has as well too. But the intention with doing conservative sharp debridement is there is no intentional removal of viable tissue. Whereas with surgical debridement, there's always an intentional removal of that viable tissue from the wound bed. So the unintentional, which is conservative. Now, that does, I should say, with conservative sharp debridement, it's if there is any damage, it's unintentional, and it's usually very minor. You know, I always like to joke with my students when I teach the sharp debridement class. A surgical debridement, when it's done, it kind of looks like a murder scene. Okay, and and I know it seems graphic, but it's true. It's going to be a bloody mess. That's the whole point of doing a surgical debridement. But when you're doing a bedside conservative sharp debridement, it darn well better not look like a murder scene, because I'm gonna make a pretty fair estimate. You've gone beyond your scope of practice on a bedside, basic sterile technique, no sterile OR, and you're hacking deep. Not such a good plan. So that's pretty much it. That's what the differences are and who can generally do sharp debridement.
Right. I know I really like the statement about sharp debridement. That's kind of like one and done.
Right. Very good. Yeah.
Serial sharp debridement. Where we're talking about conservative sharp debridement, there may be more than one application. It may be more frequently until we get a wound cleaned up. But when we're talking about surgical sharp debridement, we're essentially thinking one and done.
Correct. Yep. And the other thing I would add to that is, from a billing perspective, you cannot bill surgical sharp debridement codes recurrently. That will red flag with the Medicare, and if you do it a lot, it'll red flag with the Department of Justice too, because they might consider that fraudulent billing. Whereas conservative sharp debridement is legal to do it recurrently, where you can do numerous sessions. Obviously, in both cases, your documentation has to support why you're doing it and the medical necessity for that procedure. That is always, that's standard operating procedure for anything in the medical field. You got to have medical necessity before you go and do something.
Right, absolutely. Okay, so that gives us a great definition of the two different terms. So when should we be doing sharp debridement? When would we look at this therapeutically?
Okay. Well, basically, and I will refer a lot to when I teach my class, because this has kind of been my area of specialty now, to having been teaching it now for over 17 years. My general rule of thumb is, unless there is a contraindication or the patient refuses, or as a clinician, you make the decision that it's really not in the best interest of the patient. If there's dead tissue in that wound, then enough dead tissue, you should be doing sharp debridement. And only because of the basic fact that it is the fastest way to get rid of it. And our goal should always be to get the wound clean and free of necrotic tissue as quickly as possible. We should not be looking at how long can we drag this process out. I will use an example I actually saw on one of the wound care forums that I follow on Facebook. And this gal had posted, and it was actually it wasn't a clinician. It was a person who was being treated with her wound, and she posted it. And she said that they had been doing Santo for 50 to 60 days now. Ooh. They had only done 2 sharp debridements in that we'll just call it 2 months. And she put a picture of the wound up, and it was still almost 75% slough yet after 2 months. And then she's wondering why the wound's not healing faster. And I would be frustrated too, because I'm like, goodness gracious, why is it taking you 2 months to debride a wound? And that's only because they were relying on Santo, which is a perfectly good product, but it's not meant for heavily necrotic wounds. They should have been doing more sharp debridement initially and then following up with the Santo to finally clean up the wound bed. Would have been a much better approach.
Right, absolutely. And she's lost 2 months' time. And then, unfortunately, the longer that goes, that wound stays in a chronic inflammatory state, and then more problems can occur just due to that chronic inflammation and all of that.
Exactly. I like to tell our students that generally, if you are using sharp debridement as your foundation, and again, we're going to assume that surgical sharp debridement is not generally the go-to, although it would be ideal because it's one and done. You can go from a necrotic wound to a completely clean wound in 1 day. That would be ideal, but we know that that is not the method that most people are using. It's a lot of conservative, which is fine. But when you're doing serial debridements with conservative, I also recommend that you combine it with a daily enzyme or a chemical debrider. You make sure you're mechanically debriding and promoting good autolysis. That way you're using multiple forms, and if you approach it in that fashion, there's really no reason why most wounds, you still shouldn't be able to have them cleaned up within about 2 to 3 weeks. It shouldn't drag on for 2 to 3 months.
Exactly. That is my experience as well. And, and that's what we're after. We're after improved healing and better outcomes for our patients. So great points. So let's talk about sharp debridement as a method of wound bed prep. Okay, and talking about that importance and just how we're setting up that wound then for success.
Okay. Well, as we talk about, and if most of you are probably familiar with the term wound bed preparation, and it's really what it means. You're preparing the wound bed in order to heal. And obviously you cannot heal a dead wound bed. Okay, that's just common sense and logic. I don't need a study to show that, okay? That I shouldn't need to prove that. We know that if the wound bed's still necrotic, it cannot heal effectively, all right? And one of the basics that Denise and I teach is one of the 6 basics to wound healing is removing the necrotic burden, because you need a clean, viable, and sometimes even bleeding wound bed to start with in order for optimal healing to occur. So that's why we like to do sharp debridement as a foundational approach when it's indicated and appropriate, okay? And there are guidelines. We'll kind of talk a little bit about that too. Some examples I want to share here towards the end of appropriate versus inappropriate times we're seeing it being done. But we want to make sure we get in there and clean that base as quickly as possible, because once the wound bed is clean, now you have a much more likelihood of successful healing and proliferation of new tissue. And that's why sharp debridement is so important, because again, back to what I said earlier, it's the fastest way to get there. So why would you choose the slowest way? Again, unless there was a reason why the fastest way wasn't indicated. It's kind of the approach I look at it from.
And many times, sharp debridement of some sort or a clean wound base too is needed if we're going to do other treatments, adjunctive therapies, things like that, because you're absolutely right. That necrotic tissue is a physical barrier to the healing. And so it's just instrumental in so many aspects of healing. And it brings that wound chemically back to closer to an acute wound, where then we're going to progress through those phases of healing.
Exactly.
So. All right. So do you have anything else to add? You were talking about appropriate and inappropriate. What were you?
Well, I mean, a perfect example was I saw again on one of the Facebook forums, I saw a student, a former, I don't know, it was one of my students, but I know it was a student of courses that I have taught, and they were a clinician. And they put up the concern that there was a surgeon that was coming into their facility and was debriding every wound every week.
Oh, goodness.
And they were saying the reason they had to do it was because of biofilm. Not because it was necrotic, but because of biofilm. Now, let's think about that for a second. First of all, can you see a biofilm with your naked eye?
Not
Generally
usually.
speaking, no. Okay? Rare circumstances, yes. But generally speaking, you are not going to see a microscopic organism, which is what is made up of, on the surface of your wound. So the first question you have to call in is, well, what are you debriding? If you can't see it, are you just randomly cutting up the base of the wound based on a assumption? Because obviously the only way to truly confirm there's a biofilm is confocal laser scanning microscopes. And let's be honest, I'm pretty sure that physician or surgeon didn't carry one around in his back pocket, okay? So there was no way he knew for sure there was biofilm, yet he was cutting up this wound every week, and the wounds weren't healing well. When you think about the physiology of healing, okay? And I'm going to talk about it in terms of an acute wound, not a chronic wound. When you have when you go in and you damage the wound bed, it's immediately going to trigger hemostasis. And then it immediately moves into the inflammatory phase, which in an acute wound generally takes about 4 to 6 days.
Mm-hmm.
All right. Well, we'll just say 6 days later, it's
We're
starting
gonna
to
do
get out
it.
of inflammation and move into proliferation. Day 7 rolls around, and what does the surgeon do again? Cuts the wound bed up, which sends it back into hemostasis, and 4 to 6 more days of inflammation. I don't know how they feel that is physiologically beneficial to speed up healing. So that, in my case, would be an inappropriate use, because again, likely what's happening is it's being used and done for payment purposes, not because it's what's best for the wound. Because I don't know, I know Denise will probably agree with me. I have healed many wounds without sharp debriding them every week.
Oh, absolutely.
Absolutely. And making them bleed every week. Right. So that is a myth when you hear people say, oh yeah, you got to make it bleed repetitively every week in order to help it heal. There is no evidence to support that approach to wound healing. That's old school. That is outdated, no matter how you think about it. Versus, obviously an appropriate situation would have been the other gal who we talked about after 60 days still had 75% slough. Somebody needed to intervene with much more aggressive, sharp debridement at that point, clean up that slough, and then get it down to a point where the Santal could be more effective to clean up the rest of the little bits of scraps of slough that might have been left behind that you couldn't really safely remove with the scalpel or the curette. And in that case, that would have been a perfectly appropriate application of sharp debridement at that time, if that makes sense.
That makes a lot of sense. Good rationale. But the one thing that does tell me is there's still so much room for education. And I hear that in my students all the time, every class. There's questions about sharp debridement, and I know that we are out there, and yes, we have live classes going. Sharp debridement is about live classes, hands-on. So where can our followers, where can our students find out about sharp debridement? Tell us about that. Tell us about the classes. Anything you want to share regarding that?
Well, I'll just throw up the website for those of you that know. It's real simple to remember, sharpdebridement.com. And basically the classes are designed, it's a one-day course. It includes didactic training on all forms of debridement. We cover it very comprehensively, very heavily in detail on all forms. We don't gloss over anything. Roughly about 50% of the class time is devoted to specifically sharp debridement. We're covering everything from the theoretical part, the billing and reimbursement, and the coding and documentation, as well as we talk about how to manage pain, how to manage bleeding, and then of course we finish the class up with the hands-on competency lab, right on, where you actually get to grab your porcine specimen, and we give our students all the basic instruments. We use scalpels, curettes, scissors, and forceps, which are the most common instruments used for bedside debridement. And then we have a very structured and organized lab demonstration where they move through in a step-by-step process using all the different instruments so they can develop comfort with using the instruments, how they work, and how to do different techniques from shaving and paring, as well as general just wound debridement, using the different tools and removing all the different tissue layers on the porcine specimens that we use in our class. So they get a really good feel. And like I said, our course, we did a nice complete update and overhaul as of January of 2020. We kind of updated everything and redid the lab, where I think it's even better than it was before, so that our students really get a lot of practice with the instruments and the different techniques, and so that when they leave the class, I think they feel confident and comfortable that I can go back and start doing this on my patients. And like I said, we don't Nobody, there's no rush in the lab part. People are welcome to go on as long as they want to. But when they're completed, we actually have a competency checklist that they must complete in order for them to be considered competent in sharp debridement. And we provide that for them. Plus, they get continuing education for the course as well too.
Right, and a couple of things that I want to highlight in what you said is, number one, porcine. There's a reason we pick ham hocks. There's a reason we pick porcine, right? Dr. George Winter did his studies back in '62 on pig skin because it was most like human skin. So as we're learning sharp debridement techniques, that's the same type environment we want our students to have, so that you can see the different layers, you can identify anatomical structure, you can get a feel for what it's truly going to feel like as best as we can in a live situation. And then that competency, that becomes really important because that's the paperwork that many clinicians may need as they go back to fulfill education for their scope of practice.
Right.
So I know I've had LPNs in my class where they're talking about, I need this competency, I need this, and so we're giving them that through that class so that they can fulfill those education as well as having the CEs.
Mm-hmm. Yep.
Right. And I think we have a question here. So hello, everybody. Hey, Jeannie. Jeannie's been one of our great lab assistants in the past, too, I know. All right, hi. All right, fantastic. Got a lot of people watching tonight. All right. Can you please describe the action of Draw-Tex on a fluffy bed sore? You want to handle that one?
I sure can. Draw-Tex falls under a specialty absorbative dressing. Okay. We don't absorb dead tissue. We absorb exudate. So Draw-Tex is going to have no direct impact on the removal of necrotic tissue. It's going to manage your exudate, but it's also going to promote a moist wound bed, which would help support the body's ability to autolytically debride the slough. But the dressing itself is not going to remove necrotic tissue in and of itself, if that makes sense.
Right, that makes sense to me. And in fact, that's exactly what we were talking about earlier in the program whenever we're talking about keeping a moist wound environment to promote autolytic debridement. Because we want the body to be breaking down this necrotic tissue even between times that we are debriding, so that we have all, every available entity trying to help us clean up this wound bed as quickly as possible. So I think that was a great explanation.
Mm-hmm.
So you have any other commentary?
Again, I would, if anybody's got any questions in the viewing audience, obviously throw them up there real quick as we start to kind of wrap up here. Generally speaking, I guess just in closing, unless we get some questions here, I just want to encourage my students that always be proactive in the debridement process. The goal should always be to spend as little time in the inflammatory phase of wound healing as you can. Because as I like to tell my students, you don't heal the wound during inflammation. You heal the wound during proliferation. So therefore, we don't really want to spend forever and a day in the inflammatory phase. We want to get through that phase as quickly as possible so that we can focus on supporting proliferative healing. And another thing about that is, again, as a treating clinician, I always tell my students, you want to be methodical in your approach. Don't try to do everything in one treatment. Okay? Mm-hmm. Don't try to debride the wound and stimulate healing all in the same treatment, because you're just fighting against each other. To effectively debride requires frequent intervention. To effectively heal requires infrequent intervention. So they kind of work against each other. So it's better to just put all your focus on debridement and get it as clean as you can, and then shift your focus of your treatment to the proliferative phase, where now you can walk back your frequency to, maybe changing every other day, every 3 days, every 4 days, twice a week or something like that, instead of this daily stuff that you may find yourself doing during the cleanup phase of the wound.
Hey, lady, how are you? We're getting some greetings from previous lab assistants. We miss you guys. We are in Vegas this week for teaching, and now for when the WOW is virtual, we're going to be transmitting tomorrow at home. So we're watching the WOW partially here and partially at home.
Yep.
But missing our wound care buddies this week, I do really want to iterate that we have added a lot of classes this fall, because we didn't get to have sharp debridement with WOW. So we want to mention that there are a lot more classes this fall. There are more opportunities. These are classes.
Yep.
We are socially distancing our students, and we want everybody to feel, safe and empowered to be able to attend, back to hands-on type learning, and definitely get those competencies if you need them.
Yep, definitely. So we encourage you guys, come on out. It's a safe environment. We're limiting class sizes, of course, obviously, because of social distancing. We work with the hotels to make sure what we can, maximally carry for student numbers and stuff like that. We've already been doing several sharp classes since the middle of August, and we've had great turnouts and great classes, and people are just, I think, they're getting to a point where they want to get back to some more normalcy. And as a healthcare provider, because we are so often working with people, okay, our lives are all about human interaction. This COVID thing, as you all know, has separated us as a society. We're social distancing, we're covering our faces. We don't, you can hardly tell if somebody's smiling at you or frowning at you. And so one thing that's nice about the live classes is it kind of gives us that chance to interact with our fellow humans and to be able to, share knowledge and network, which is another very great thing about doing the live classes again. So we're excited to be back out there, and we'd love to have you come out and join us and expand your wound care knowledge so you can continue to become a greater and greater guru, so to speak.
Absolutely. Hey, Bill, I think we've got a question there. Hello from Puerto Rico.
Hey, Puerto Rico.
Yeah, that is one of my favorite places to bring our classes as well. All right. All cause of diabetic's wound is obligated from malleolus to foot. I believe what you're asking is the consideration of a diabetic foot ulcer, potentially. And yes, that is defined as a wound below the malleoli in a diabetic.
Correct.
Right. I believe that's what you're asking.
Yeah, I think she's just looking for, when you classify it as a DFU, where does it have to be located? And since you just taught the diabetic wound certification course there, Sunshine, she might know the answer to that. Even though I do, I'm going to default to her.
That is one of the great things about sharing passion, in our family, and with my partner in life, my partner in business, and my partner in life. So I appreciate that. You are very, very welcome. So, all right, Bill, I'm going to let you wrap up.
Okay.
I don't think we have any more questions.
All right, sounds good. Well, I want to thank everybody who tuned in with us tonight. And obviously, this will be recorded. It'll be available on Facebook, our Facebook page, so you can check it out there and share it with your friends if you felt that the information we shared would be helpful for them to know. We also have our YouTube channel, so YouTube / Wound Care Gurus, and you can tune in there. All of these videos are posted up there. We've got a library of videos that we have been doing these interviews and clinical talks since, I believe, May. And we've got a lot of good content, so I would highly encourage you guys to check it out if you're learning about different aspects of wound care, different products, different technologies. We've covered a lot of things, and we will continue to bring these things to you all. So I want to thank everybody for tuning in. Enjoy, for those of you that are attending the WOW conference virtually, enjoy the rest of the conference. It is jam-packed. Check out this lady's talk tomorrow morning at 10:20. You will not want to miss it. And if you don't watch it, I'm going to hunt you down and track you down. Just kidding. But we are looking forward to everybody and seeing you all in the future. We want to just say God bless to everyone, safe travels, and be safe, and let's heal on. Everybody have a great night. Thanks for tuning in.
I will see you in the morning.